Good afternoon, everyone. My name is Flannery Peterson, and I'd like to welcome you to the Operationalizing Value-Based Reimbursement webinar. This webinar is brought to you by the National Council for Behavioral Health. Before we get started, I'd like to draw your attention to some important webinar logistics. Today's webinar is being recorded. An audio version of the entire webinar and a PDF of the presentation will be sent to you via email and posted to the National Council website within 72 hours of the webinar. A copy of the slides are also available as a handout. You are currently in listen-only mode. You may send us questions to the speaker at any time during the webinar. Simply type your question into the dialog box to the right of your screen and send it. We will answer as many of your questions as time allows. There's a lot of content to cover in this 30-minute presentation, and the questions not covered will be shared with David to respond to over the next few days. If you experience technical difficulties at any point during the webinar, please call Citrix Tech Support at 888-259-8414. I will also type that phone number into the chat box. And now I'd like to turn the presentation over to David Lloyd from MTM Services.
Thank you so much, Flannery, and good afternoon, I guess it is, and some good morning, depending on the time zone. It's a pleasure to be with you today. I want to talk about a very important topic, value-based reimbursement. Payment reform is certainly a tremendous amount of discussion going on nationally. I just had a discussion with one state, the state director, yesterday on global payments. That movement is happening in one state. So I really wanted to take today and really spend 30 minutes, a very short period of time, but to try to convey as much information as possible around how do we move to value-based reimbursement. And what I want to talk about is the philosophical approach versus the C-level operational approach. C-level is where we serve the client, where we work with our staff, where we have our day-to-day activities at C-level. And what I'm finding is there's a lot of value-based learning opportunities that seem to be available out there. But primarily it's on the concepts of value-based reimbursement. What is the concept? What does it mean? What my concern about this conceptual approach is that it's certainly popular in that what I had one person said, well, the reason they use conceptual ideas is less threatening to the CCBHC's management team or to the local behavioral health management team, and to talk about shared risk funding as a concept instead of as a practice management operational requirement. And so today, I think what I have found in the last several months, I think there are definitely good conceptual discussions going on out there. My concern and the concern of our MTM Services consulting team is that they don't seem to lead to implementation of the very change elements that are needed to move the value-based reimbursement concept into service delivery reality. So today, in the 30 minutes we have, I'm going to try to focus on not conceptual ideas, but actual realities of what needs to happen at the local community behavioral health clinic to make sure that you are value reimbursement capable and ready for that type of funding. So let's talk about what type of funding that's involved typically with value-based reimbursement. And typically the red items here on slide 3, you will see bundle payments, episodes of care payments, stratified case rates. Case rates have been around for quite a while. 8 states now with their CCBHC pilot status will be using prospective payment system, which is a per day visit payment or a per monthly visit payment, which is all services are wrapped into that payment. Global payments, again, we have now 3 states that are moving to global payments, with one state moving to SPMI. Adults are going to global payments, which means we're going to basically give you a pot of money to take care of all the needs of the client for a period of time. And you have to internally basically provide the utilization management and the service delivery focus and the level of care criteria to make sure that you're staying within your global payment. But if you save money, then you get to share in that. If you don't, then there's a penalty for that. So shared risk, value-based, means what value are you bringing to the table for the payer or the MCO or the accountable care organization. What is value-based reimbursement? Several years ago, the National Council asked MTM Services to come to this definition of how could you operationalize the components of value-based reimbursement. There are 4 basic components, and the first 2 are here on slide 4. First, we have to have an ability to identify services. And that means a measurement capability, an information system, if you will. And I'll show you some reports out of an SPQM information system that shows you the type of reports. But I must see what services are being provided. I must also, do I use a level of care benefit design? Do I use evidence-based practices? If so, what does that look like, and am I getting the outcomes that I need? But also, I must have in services, I must have timely access to both clinical and medical services. And I'm going to talk more about that. In other words, if we have good quality services but no one can get in, if you can't get in to see a psychiatrist for 2 months, is that really of value to the payer? Those are questions. The second thing, and Scott Lloyd, president of MTM, is going to provide another luncheon webinar next Wednesday, the 29th of March, same time, 12 noon Eastern Daylight Time, on cost finding. And so I will not go into as much detail today about this particular element, but it's critical. I can't measure value unless I know my cost per billable hour, per CPT or HCPCS code by staff type. Now, in one state where we do measurement for the whole state, they want to know not only the CPT code roll-ups, but they want to see the CPT codes and each modifier cost and net revenues. And they want to see it from an MD versus an advanced practitioner for a 99213. In other words, if I am a community behavioral health center trying to move into value-based reimbursement and I do not know my cost, it's very hard to really know how to measure value, because ultimately the services you provide at the cost of those services tied to number 3, the clinical outcome that you've chosen to use, then determines number 4, whether you have value or not. And again, I'm going to illustrate this with actual reports so that you can see how this works. Identify the client level outcomes is the third component. So again, I'm going to go back just for a second to number 2. One question that you might ask, and I've asked this of thousands of staff because we work with over 800 community behavioral health clinics, statewide, regional organizations over the last 25 years. And what I've found is when I've asked staff, what is your cost for a 99213 or an H0036 community support hour, most staff don't know. And so again, if we don't know cost, that's why that webinar next week will be very important for you to perhaps attend. Number 3, what client level outcome are we going to use? And this is critical. HEDIS measures are really process measures, and they're very good measures. They're required by most MCOs today. They're required by a modified version for SAMHSA with the CCBHC 8 pilot states. So basically, are you doing the processes that should render good outcomes? What we're talking about is, can you demonstrate that the clients you're serving are getting better or not? One of the measurement tools that I've worked with since the mid-90s is the DLA-20, which is measuring 20 activities of daily living. And the reason I do that is because of the sub-bullets here on number 3 is that it's inter-array reliable. Right now, over 11 states have adopted the DLA-20 statewide. I can use it with all staff types and get the measurement that is comparable between MDs versus LCSWs versus bachelor's level staff. It's a focus tool that can be done at the initial assessment and then every 90 days to support treatment planning and where are we going to go in the next 90 days, and I'll demonstrate that with an outcome slide. And it identifies the functionality levels of persons and their daily living activities based on the remaining symptoms they have. So it's not a symptom-based tool because it can be used for any diagnostic group, but it's really based on how the symptoms of that particular diagnosis are still impacting the person's ability to function within the 20 activities of daily living being measured. And does direct care staff consider it a helpful tool? We find a lot of tools that are being used out there. Number 1, we have a lot. One of our blessings in behavioral health is we have hundreds, if not thousands, of outcome tools. That's our same curse, though. We have so many that we do not have comparable data. Within one community mental health center, we may have multiple tools being used. And so again, one of the suggestions here is you as a center are going to have to accept or adopt one tool. Your statewide group needs to adopt one tool. As I said, 11 states have done that with this with the DLA-20. But I'm suggesting that we've got to get beyond the adult tool, the child tool, or the DD tool, and the substance use disorder tool, and the mental health tool, because we don't have comparable data. Because ultimately, the outcomes you achieve with your client level outcome tool is basically tied to the cost it took, number two, what cost it took for the services you deliver to reach those outcomes, which ultimately measures the value. And again, I'll show you that in actual measurement. If we were to give you C-level action steps, and these are our MTM consulting team has developed, these C-level action steps we think are absolutely critical for you to implement value-based reimbursement, not conceptually, but to actually do it. And I don't have time to go into each of these, but I want to give you a couple of highlights. Number one, you do need to develop a strategic business action plan that supports value-based reimbursement, because that's going to require that you look at your back office staff, your internal utilization management. It's going to require that you implement number four, same-day access for clinical and just-in-time 72 hours, 3 to 5 days access to medical services, initial and ongoing medical services. You're going to have to develop key performance indicators. You're going to have to look at the cost of your services, number two, and the revenue that you are getting per CPT, per HCPCS codes. You're going to have to look at gap analysis. How long is it taking you to deliver a service delivery processing? What are the costs involved? What is the time required for staff and the time required for clients? You've got to look at risk stratification tools, and again, I'll be showing you one of those in just a minute. What is our client base, and what are our risks with that client base? And so where are we with a value-based reimbursement contract? I need, number 8, a measurement system. I need an information system. I don't need data. We have tons of data in behavioral health. We punch out more data than probably any other industry. What we don't seem to have is information for clinical and administrative managers and staff to use to see what our service delivery process is doing around cost being achieved versus net, around no-show performance, around whatever you need to measure to show the value, if you will, around the outcomes we've achieved. We have to, number 9, implement a standardized tool. Whatever it is, make sure it's inter-array reliable, that your clinicians feel like it's, direct care staff feel like it's a positive help to them, not a negative. And we have to implement back office. I have to look at payer diversity, revenue cycle management, claims, internal utilization management. You see, from the business action plan, which is not a strategic plan, it's a strategic business plan. And there are certain elements of that I'll discuss at a workshop, in fact, coming up at NatCon 17, which I'll show you at the end. But out of all of this, once I program this into my action plan, then I'm going to develop a business case that provides objective information for collaboration or for contract negotiations that shows your unique or your individual center's unique factors around value. Can you get people in time? That's a good value. So let's break these down, if you will. After implementation of these 12 essential local value-based reimbursement transformational changes, then you will have the ability to determine a level of value. And within your business case, you will be able to differentiate your CBHC from other providers in the marketplace. And when we come to value-based reimbursement, that's what it's going to come to, because the last slide I want to show you today, I'm going to ask you to make a value-based payer-specific value-based decision and let you make that decision and determination. So let's go in and break some of this down around the services. As I said, there are specific value elements for getting people into treatment. In MTM, our team has worked with over 550 community programs nationally now to implement same-day open access models, secondary access in 3 to 5 days. What we find is if we can get people after their initial assessment into treatment within 3 days, we're going to capture about 96% of the clients. If we wait to 5 days, it's going to be about 93%. If we wait to 8 days, it's going to be about 89% of the clients. And in value-based reimbursement, you must get them into treatment. If they're not in treatment, you're certainly not going to produce a value, and you're not going to be able to reduce high-cost services if they're dropping out because you can't get them in. And in tertiary, from the day they're assessed or contact you for assessment, how long is it taking you to get them into a psychiatrist for initial psych eval, advanced practitioner, and for follow-up meds? And the just-in-time model, which we've implemented now in over 15 states with MTM team members, is basically getting them in 3 to 5 days. And what we're learning again is no-show rates are dropping from the 30s down to the 4 to 6% range, because we're not asking clients to schedule themselves out 3 months. Now here's a risk stratification tool. This is an SPQM report that we do routinely, but what it allows you to see is based on the DSM-5 levels of severity. You can also use the ICD-10 fourth digit indicator, and this is for all persons with schizospectrum under the new DSM-5, but basically that's the only clients we have identified here. How many are in severe impairment levels based on the DSM-5, and what services are we providing to those clients? So I can start to look at my risk stratification. If I'm going to do a stratified case rate, my case rate should be higher for my severe impairments versus my moderate impairments, because I have more intensity of service and a larger service array typically to deliver. So again, this risk stratification allows me to see where I am in contract negotiations, in this case for all persons in my center that have schizospectrum disorder. Now the value. Let's look at actually here the cost of services. And again, I'm not going to go into detail. Scott will cover this much more next week. But basically what it comes down to, MTM services and our standardized cost finding tool we have implemented now in over 6 states. It says 6, but here's the outcome from 125 community behavioral health centers, including substance use disorder IDD centers in the 6 states that we have in this chart. But I can look now at the staff type. What is my cost in red, my net revenue collected in green, and what is my loss for each staff type in these states? And what you're going to see, typically master's level license, you're going to see a significant loss typically nationally. Also medical, which we would expect around the rates we are paid versus our cost per hour. So we can look at that. In the case of your individual center or statewide associations, which we again have done quite a few of those now, is we're going to provide a per CPT or HCPCS code per billable hour cost per hour and net revenue per hour. And then for the individual centers, and Scott will cover this with you, you're going to be able to get your local cost and revenue for an H0036 billable hour, which is community support, psychiatric community support, and you're going to be able to compare that to your weighted average for the state. Now this is important. If you are a management team member and your center's cost for an hour of community-based bachelor's level service is $171.23, for which the average peer group, your other peer group centers in your state is $98, and you're only collecting $79.55 and the average other center is collecting $114. Do you think that this level of objectivity will give you the ability to make decisions about changing your community-based services? It's not good or bad. It's just saying the objectivity is what we're talking about. Now you can also, with these applied costs within centers, and these are just sample de-identified centers on the left, but we can actually, in statewide measurement, this is an SPQM statewide report de-identified, we can look at cost, revenue, and net by service type at the top for case management, day treatment, whatever type of service we want to look at, and to start looking within those centers to say, why is one center doing well and other centers are not? Not good or bad, it's just can we system learn? Another activity of cost-based reimbursement is that with all the services, and these happen to be all persons with SPMI, these are the centers across the bottom. What is your average case cost per year? And if you're being treated at RLC, it's going to cost over $3,000 a year per client for an SPMI outpatient client. If you're being treated at HVC, it's going to cost the payer $698. Now, that's an important piece of information because typically we don't know that piece. We don't have the cost information. But secondly, I need to combine that with value. In other words, I need to look at the outcomes. And what I've done on slide 17, there is a URL address here under the National Council's website. I would strongly suggest you go to this address and pull down both the Advancing Standards of Care outcome study for the schizophrenia, persons with schizophrenia, and the second one we did was persons with bipolar disorder. I would encourage you to read those outcome studies. Again, it can give you a tremendous amount of information about how to objectively measure value. The long and short of it is this, is that in effect, the column here in white is a baseline for persons with schizophrenia in that particular 510 cohort persons with 10 different mental health centers being used around the nation. The red column is at 180 days, 6 months later. And what you see, the higher the column, the higher the functionality on the DLA-20. The boxes or topics here are the 20 ADLs that are measured. So what we were able to demonstrate in this 6-month study for persons with schizophrenia is they were significantly functioning higher in hygiene, groom, stress, coping and norming skills, safe sexual practices, friends, reduced cigarette, alcohol, drug use, more in family involvement, et cetera, et cetera. Also, though, we can also see the areas where we are not making progress, and that would be our focus for the next 90-day treatment plan review. Same thing with bipolar disorder, the 20 ADLs on the left, statistically significant change in 180 days for 551 persons with bipolar disorder who participated in that particular grant. I would encourage you to write, again, pull down those written reports. Another thing I would encourage you to do on value, client level value, is that you need to ask your MCOs, ACOs, or your state, what do they determine to be good value indicators? And this is a very important thing. Now, again, they may cite HEDIS measures, and HEDIS measures, as I said, are very important process measures, but it doesn't necessarily demonstrating that if you're doing this every time the client comes in, or 80% of the time you're doing body mass index, it doesn't necessarily say that clients are getting better. So in effect, the client level tool we think is essential. To this point, I was engaged by the Georgia Department of Behavioral Health, their mental health division, adult mental health division, and they asked me to work with them on the outcomes. So I asked the state staff, what elements do you consider to be good indicators that if your providers are doing a good job with the clients they're serving, with the money they're getting from the state and Medicaid, Medicare, et cetera, and they came up with these 12 indicators, very objective, stable housing, reduction in substance use, enhanced wellness, et cetera, very positive. So what we did, that was the morning time. In the afternoon, I met with all the Georgia CSBs through their association and members who were representing CSBs there, and we went through various outcome tools. The BASIS 24 self-report, the PHQ-9, the ANSA for adults, the crisis tool. We also looked at the MHMR, we looked at the MISIP, and we tried to find if any of those outcome tools addressed and measured the indicators that the state wanted us to measure. And the only one we could find, which is the white here, was the DLA-20. So again, what I'm suggesting is you find as objective as you can from your funder payer, the ACO, the MCOs, what indicators are they looking at client level that show value, and then you determine a tool that can in effect measure that value for you, and then use that tool. For instance, in the DLA-20, we also are able to crosswalk the DLA-20 scores to the level of severity in the DSM-5 or the ICD-10. Not good or bad, but what it does is when the clinician uses this tool, it automatically links to the DSM-5 level of severity, or to the ICD-10 fourth-digit indicator. Very important. The other way we're measuring outcomes or positive outcomes is what we call delta scores. Delta scores means we measure every client, their DLA-20, when they come into care. That's their baseline. And then we remeasure every 90 days the DLA-20. And so when we look at delta scores, we look at the difference between their intake DLA-20 and their most current, which would be within 90 days technically. And so as you see here in this particular what we call a value of care stratification, anything to the right down here at the bottom, to the right of the vertical line, is a positive improvement in functionality since their intake, and this is all clients served. Anything to the left shows a decreased functionality since their intake. Anything above the center line horizontally is there's a positive net revenue over expense or cost of the services delivered. Under the line is a negative revenue over expense. We're actually losing revenue or money on that particular service array. So the point here is, where are we within these quadrants? Obviously the quadrant we're targeting for would be quadrant 1. Now quadrant 4 is we're actually producing good outcomes, but our costs are higher than our revenues, the rates we're getting paid. Now to the left you can see, again, we're having negative outcomes and negative revenues. So quadrant 3, if we have a lot of clients in quadrant 3, it not only puts the center at risk financially, but it also does not show value. So with these particular quadrants that we're measuring, we can then take that and we develop a report. And so what you can see now, anything to the right here, for this particular group, this is 44,000 persons in this data pool that we have in this particular state, but we're saying other substance use disorder clients are getting much higher functionality ratings, meaning they're improving functionality. Dysthymia, we're actually decreasing their functionality. We look at adjustment disorder. They're functioning less at the most current DLA-20 than they were when they came into care. So what's that about? The other part of this, too, is that you can also look at it by a specific client. So if I'm the quality improvement director for a particular center, and I'm looking at this quadrant, everything to the right of the clients who've improved functionality since intake, everybody to the top has a net revenue over expense in their mix of service, but everybody to the left here, this vertical line, is basically decreasing in functionality. Then if I'm going to pull a chart audit, or if I'm going to do peer review chart audits, I'm going to pull these clients. Why are they not improving in functionality? Is a leading indicator that they're getting better. So again, as you can see, it comes down to this particular chart at the end. I'm going to ask you this question because it's a very important one to ask. If you were the payer, the MCO, the ACO, Medicaid, Medicare, third-party insurance, and you were going to contract with a behavioral health center, and these are the centers up across the bottom by a three-letter abbreviation. And what we have on the bottom particular column chart is that we have the cost per year for persons with bipolar disorder. There are 3,800 people, 38,000 people. This is SMI, SMI. But the cost per person for SMI, and so at MCT, if you have an SMI type adult client, it's going to be $1,000, a little over $1,000 a year in cost for outpatient. Now the top chart is the level of functional improvement or actual decrease in functionality you have with that SMI population from the time you took them into care to the most current measurement within the last 90 days. So now if you're the payer, which one of these centers would be better value? And you've got to look at cost compared to outcomes achieved, and that's determinant of value. So in this case, my hope would be that you chose DRC or PKC because for the money they have spent per case, they have rendered much better outcome than their peer group. What I would be concerned about is BLM. I'm spending almost double, almost 2.5 times DRC's money, and I'm rendering half the outcomes. So again, you can start to see how value will be determined. And that's basically the operational level of value as we look at it. The slide here, 27, it gives you 2 workshops that I will be presenting and co-presenting, one with Mike Garrett, who's CEO of Horizons Mental Health out of Kansas. Mike will actually give you a case study of how he has implemented each of these value-based models at his center. He'll actually have outcome data there for you and talk about what he's done with that. And then the second one is a workshop, if you're going to NatCon 17, on the components of measuring and reporting outcomes. So let's open it to questions if we can. Flannery, if we have a few minutes for questions.
Great. Thank you, David. There's one question that we received earlier in the presentation, and what is the applicability to behavioral health within integrated primary care settings?
What is the accessibility to behavioral health within primary care settings?
Applicability.
Applicability. The applicability of this is very much the same. In fact, if you look at value-based, whether you're in primary care, behavioral care, SUD care, or even IDD care, you're still looking at the same concepts. Do we have accessibility? Is it timely? What are we spending in terms of our service cost? What outcomes are we achieving with that? And what's our case cost and the versus outcomes achieved, which is ultimately the value to the payer. So I don't see any major difference in terms of applying the same concepts to primary care or behavioral health within primary care, if I understood the question correctly.
Thank you. And then we have a couple seconds left for 1 or 2 more questions. The first is the DLA-20 usable in the MIPS quality metrics?
Mm-hmm. Again, the question is the DLA-20 a
usable in the MIPS quality metrics?
Yes. Yes, it is.
Next question is, do you have an outcome tool you recommend for an agency that works primarily with children?
Again, the DLA 20 youth version has been very successful. Adolescent youth version, there's an adolescent version, for I think 13 and older, and then under 13 down to 6. Some centers are using for under 6. They're using the PECFAS or the which is a version of the CAFAS for the under 6 population. But those are the typical ones we're seeing around the nation.
And there are a couple more questions, but David, since we're out of time, I can share them with you offline, and then we can get the responses to the attendees who asked.
Very good. Be glad to do that. Thank you, everyone, for attending today. Again, very short and sweet, I know, but I hope this information has been very helpful to look at the operational aspects of value-based reimbursement and the changes you might need to undertake at your local centers. Thank you, everyone.
Thank you, everybody.
Have a great day.